Welcome to this brief presentation summarizing the results from our qualitative study that was trying to investigate needs and expectations for instruments in primary care settings designed to test fitness to drive. Well, what we do know is testing fitness to drive is not only about detecting substances. Much more complex situations such as cognitive decline or polymedication or psychiatric conditions require an individualized assessment. This is, however, difficult to do because often neuropsychological tests are not really associated to driving performances. So what we've done is actually asked experts and primary care physicians to assess this. In many countries, from 70 years onwards, senior drivers are required to see their physicians on a regular basis, and those have to attest that they are fit to drive. They have, however, reported difficulties in doing this and require new instruments. To answer their needs, we have organized a qualitative study where we questioned 5 experts, 5 primary care physicians, and 5 senior drivers on their needs and expectations for instruments to measure fitness to drive. These were entirely recorded and transcribed, and then we had 2 independent researchers who extracted quotes and coded these. These codes were then compared to the literature to make sure that the concepts, underlying concepts, and the way we actually constructed this structure was conformed to what was already known. So what were the results? Well, the main point is for any instrument to be integrated in clinical settings, it needs to bring something to the decisional process. To do this, 5 criteria were needed. It needs to be adapted to different clinical conditions. Also, results need to be contextualized to specific conditions in which the tests were done. The instrument also needs to reduce the range of uncertainty to provide an input to the clinician and help him in his decision. The instrument needs to be adapted to local resources and possibilities. And finally, the procedure needs to be accepted by the patient. We'll see each of these points one after the other. If we look at the overall table on frequencies, what we can see is that each point was not equally quoted by expert physicians or drivers. The fact that test needs to be contextualized was mainly evoked by experts and physicians, but drivers apparently felt less concerned about this problem. This was even more the case for the reduction of uncertainty and also the adaptability of the instrument to local resources and possibilities. On the other hand, while the acceptability by patients was mainly evoked by the patients themselves. Let's take the first point, adaptability to different clinical conditions. What do we mean by this? Well, there were 3 underlying concepts. First, the mode. We found that physicians would use instrument in 2 different ways. One was ecological screening, meaning that they would use the instrument on all their patients to detect things that were not suspected. The other mode is only test uncertainties, meaning they can perceive fitness to drive as a situation where either the situation is clearly okay, so like a green light, or the patient are clearly unfit to drive, and a red light, 2 situations for which they don't need to do tests. In these situations, they only require to do the tests when the light would be orange. In other words, they're not sure. The patient is in a transition phase where he's starting to become unfit to drive. This requires 2 criteria. You only need to investigate suspicious signs, but also physicians need to reliably identify all the tests that are useless. Another criteria is the context. We found 3 of them. Physician might need to assess fitness to drive when a new medical condition is discovered, following a stroke or after the diagnosis of a disease such as Alzheimer's disease, Parkinson's disease, but also after the initiation of a medication. The second context is the monitoring. Once a patient has been assessed unfit to drive, it is important to see when can he drive again. This can be done by following the patient up, but also requires undergoing tests to certify that he can drive again. The third is the checkup. This is simply following patient up and testing them to either comfort them in their situation that they are healthy and that they can drive, or to detect those that start not to be. Finally, there's the final objective. Why am I doing these tests? Well, the first objective that seems quite straightforward is to prevent road accidents. This requires to identify unfitness to drive, but also when people are fit but report driving difficulties, maybe it's also identify lack of experience and know-how, which might require further input from either a driving instructor or different courses. And the physician can actually ask their patients or suggest them to do these courses. However, our study showed that there were other objectives that physicians have mentioned. This is to optimize the quality of life of their own patient. By having cognitive tests, they can actually detect diseases quite early, and this seems quite important for them and also for public health interests. They also like to anticipate future difficulties. This means that by detecting the start or the initiation of difficulties, well, they can talk about it with their patient and prepare them to their driving cessation. Another point they mentioned, and can be an objective, is about reassuring their patient about their health conditions. Patients also appreciate knowing that they are well, and this actually might decrease their sense of anxiety towards different diseases. And finally, some physicians have mentioned the use of these tests and also the threat over the fitness to drive as a mean to tackle health issues. This is mainly related to alcohol problems, where physicians actually use the threat of patients not being able to drive to help them overcome their difficulties and recognize their drinking problem. Now we'll see about the interpretations of tests and why for physicians and experts and patients it seems important not to have a straightforward answer on their fitness to drive. First point seems quite easy. People have to take into account that unplanned difficulties can occur during the tasks. Second point is the concomitant medical conditions. Accumulating different slight difficulties might occasion a more severe overall effect that could actually make people unfit to drive, whereas only having one function that is slightly under the norm would not have much consequences, as people can adapt themselves. Therefore, physicians have to account for the overall situation in interpreting the tests and knowing if this really does have an effect on fitness to drive or not. Another point is the history of driving. This seems quite important because people focus more on what's happening if there is already a history of driving difficulties, especially if accidents have occurred recently and occurring more and more often. This also requires physicians to investigate lapses and accidents, but also transport needs to find the barriers within patients to actually stop driving, and also to what point are they actually self-conscious of their problem and that they're actually putting into place compensation strategies. Another point is complementary investigations. Once some results are seen, physicians will require knowing why are the patients unfit to drive. This might require specialized consultations and also complementary exams. Furthermore, some situations might not be so straightforward, and physicians might not be certain that their condition really does affect driving, and therefore they might rely on on-road tests or psychomedical expertise to help them convince their patients that it's better that they stop driving. Finally, well, pre-existing opinion also has an influence. This can be by physician's concern or family or friends' concern during follow-up, as often patients see their own GP. This will, of course, influence the physician's interpretations of test. However, experts have mentioned that often physicians tend to overestimate their patients' driving capacities. Now, for scientific, this seems quite evident, and it is also to clinicians. An instrument needs to reduce the range of uncertainties, meaning that it does provide an answer that helps in the decision. But there's other points that physicians have mentioned. The instrument can serve as a checklist to help them not forget to think of a point and make sure everything is fine. Also, the instrument might also compensate some lack of expertise in fields in which they are not trained. This also requires the instrument to have a proper training and also to have very clear instructions on how to use the instrument itself. Of course, all the components of the instrument need to be valid. Maybe the most important point is that it needs to relate to driving, meaning that if you're using neuropsychological tests, well, these need to have an implication on driving, and that these can be explained to patients. Another point is that physician experts and patients like the idea that whoever they would have seen, well, they would have had more or less the same assessment and the same conclusion. This is a sort of standardization. This does not mean that the test has to be exactly the same for everyone, because it can be adaptable to a patient's situation. But whoever would undergo the whole process would do it more or less the same way. Finally, well, it would be nice that the test can actually predict events in time, either regarding driving difficulties, but also the evolution through time. This helps physicians be able to talk to their patient and help them anticipate future driving cessations. The instrument needs to be adapted to local resources and possibilities. Well, they need to have access to the instrument quite easily. This both concerns costs, but also it concerns the material and the space that would be needed to use the instruments. The most difficult point is the adaptability in time. Physicians often don't have much time, so the instrument must require the less time as possible. And finally, well, the whole process needs to be conformed to legal constraints regarding fitness to drive. Final point is the procedure needs to be accepted by patients. Well, what we have seen is that patients have expectations about the results. They also have expectations about the whole procedure. They expect it to be the truth. They trust their physicians, and they trust that if their physician tells them that they can't drive, he must be right. But on the other side, well, they expect that the results will be related to their self-perception of their own driving competency. That means that if the result that is provided by the physician is not conformed to what they self-perceive, well, this will induce a loss of trust in their physician. To help overcome this, well, the form in which the instrument is provided is very important. We've divided it into 3 different parts: the instructions, the execution, and the restitutions of the results. During the instructions, it's very important to specify the aims. Why are we doing these tests? What do they provide, and how are we going to interpret them? This also means that the future contextualizations of result is very important for patients. This helps also trivialize repercussions and helps people feel less stress when they're actually doing the tests. During the execution, well, experts have mainly pointed out that it's very important that the tests are simple and fun, whereas the patients themselves don't seem to mind so much as long as they know why they're doing them, and that they see what the aim is and how this relates to driving. For the results, this is maybe the most difficult point, and the one for which we need to invest time and resources to provide the best input. In other words, there's no use of having a result that will not be accepted by patients, because patients might still drive even if they don't have their driver's license. So it's very important that in the interface, well, the patients really understand why things are wrong and how this really implicates on their driving ability. So first of all, what we've seen that people like having crude results given to them, comparing it to others. They like to be situated compared to other people of the same age as they are. If results aren't positive, they like a clear and brief conclusion on the causes. Why can't I drive? But more important is to discuss the consequences. What will these results, or what will my condition actually do to my driving competency? This needs a thorough discussion, and also to do correlations between what patients have already observed in their own driving. Finally, when possible, it is very important to make patients take the decision to cease driving instead of imposing it to them. It is important that the physician suggests it, documents the whole processes, and maybe even incites them to stop driving. But the more he can do to make the patient take the decision, the more likely the patient is to accept this decision and also apply it in his daily life. This requires communication skills. When you're using an instrument, the aim is to support and depersonalize the procedure and decision and maintain trust. But the mean to do this is that not only does the instrument itself be totally free of judgment on the person, but the physician that's doing the test also needs to show this absence of judgment. The other point is that the physician needs to manage his own and the patient's emotions regarding the tests and the results from the tests. And also, when results suggest that the patient is unfit to drive, it seems very important to plan sufficient time to discuss about the serious condition. Apparently 20 to 30 minutes and maybe a separate visit could be necessary to discuss these points. So if we summarize, there's maybe 3 important points to remember about the development of instruments in primary care settings. The first is that the instrument needs to inform both physicians and patients without imposing the result. The second is that all components included in the instruments needs to be related to driving, both for communication purposes, but also for the patient to understand the results. And finally, well, the instrument needs to include all the material that is necessary to help physician communicate about the decision to take. This often is not provided, and us scientists often tend to stop once our instrument has been shown to be valid, without taking the time to say, well, how do these results need to be communicated to patients? I thank you for your attention, and please feel free to email me or my team if you have any further questions.